Welcome to all the panels. Over to you, Recurrent, please.
Thank you. Yeah, I just need to share my screen, I guess. I've got my talk on. Can you see me?
We can see you, but we can't see the shared screen yet.
Okay. Let me just... is it share screen that I need to go to?
Yes,
yeah.
You go to share screen.
And then share at the bottom here.
Yeah, we are seeing your laptop now. So you.
Yeah, great. Okay, can you see the presentation? I'm just going into.
Yeah, we can now. Thank you.
Okay, and then we got everybody online except probably the Australian guys who are still probably sleeping their handover to the kind of 3 o'clock in the morning. Is that correct, Shahid?
Farouk said he would join, so I'll just give him a minute. No, I know he was awake 5 minutes ago, so I'll just tell him.
Oh, poor chap. Anyway, it's 3 o'clock in the morning in nothing, or 3:30 in the morning in Sydney. So he might have kind of gone up for a wee and may join us. Anyway, so I've got a very distinguished faculty. I don't know whether Johan is also joining us from Cape Town. Shahid, do you know?
I'm here.
Yes. Oh, yes. Johan, how are you?
I'm well, thank you.
Good. Okay. So we are going to. We got a few things to discuss, and also we've been picking up some questions for you guys along the chat. I have to say that it's been a really fantastic afternoon. To really have you here and to hear your talks. It's been really, really great. And as always, I mean, I heard quite some of these talks a few times, and you always pick up a new thing. So it is really, really great to have you here, even if it's just online. So also we've got a Jay Manik from Dundee, who's going to basically step on to make the bulk as the Australians are in deep sleep. So we'll have Vim Paleri, we have Guri Sandhu, we have Johan Fagan, and then Jay. So there's a few questions mainly for Johan. One colleague asked us as to why, how do you actually manage the intraoperative spillage in kind of pleomorphic adenoma? What would you do if you have noticed that there's you spill some tumor in the intraoperative field?
Right. Well, historically, when I trained so many years ago, spillage was an indication for post-op radiotherapy. But since then there've been a few studies not that good, which suggest that as long as it's a controlled spillage and you wash the wound really well, that you probably don't have to radiate them. And so, but I think the one exception would be if you're taking out a tumor of the parapharyngeal space and you get spillage, because we know that you can deal surgically with mixed success with recurrence in the parotid bed. But but the worst recurrences are the ones you see in the parapharyngeal space, where you just know you can't clear them surgically. So if there's spillage in the parapharyngeal space, I would have a lower threshold for actually offering the patient post-op radiotherapy. But the parotid area, if I feel that I've washed out the neck really well, then I'd probably just observe the patient.
Okay, thank you.
I'd like to hear opinions of others. It'd be interesting to hear what people say.
Yeah, I mean, do you want to comment on that, Vin? What would you do, if you have that sort of kind of setting?
I agree with Johan. Gone are the times when we thought we should always radiate spillages. If we know it's a benign tumor, there are a few studies to indicate that in the long term too, the chance of disease recurrence, that parotid bed, is between 10 and 15%. So I think it's overkill to radiate them. And we also have broad clinical consensus among colleagues about this. So in the UK, if you recall, we had a consensus meeting a while back which reviewed the evidence, and the consensus was you're better off not radiating the spillages. We were divided whether we should wash the wound out, because washing could potentially propagate the small seedlings and cause multifocal spread. But the broad consensus was whether you wash or not, don't irradiate, wait for it to happen. But as Johan said, if it's a parapharyngeal spillage, then you're in a bit of a bother. And that is a really difficult one to salvage. And the options are whether you want to carefully watch them, regular MRI, and then intervene as appropriate, or radiate.
Yeah. And then the other thing is that, I mean, we all, I guess, spillages, but how do we actually kind of, I know in the parapharyngeal space may be quite difficult, but in a kind of, really in a standard sort of kind of prostatectomy, how we kind of, as surgeons, we can actually, prevent, and obviously the handling of the tissue is actually very important, just emphasizing that your registrar, or your assistant doesn't actually, retract too thoroughly into the and then just having the strategies basically just to work around the tumor. If it's a tumor which is actually to attach to the tympanic plate, just perhaps do a kind of a peripheral approach. So what is your kind of view, Johan, on how do we actually prevent spillage?
Well, I think you already alluded to that. I think the main cause of spillage is an overly sort of aggressive assistant, and so I think one really has to be really careful that the assistant doesn't use a right angle retractor on the mass, especially if it's cystic. That you retract the tissues adjacent to it. If you're going to use a sharp pronged retractor, make sure that the retractor doesn't go onto the mass but goes onto the adjacent tissue. So I think it's really a matter of watching your assistant. I think, and instructing your assistant very carefully how to do the assistance.
Okay, thank you, Jay. Do you have a comment on what Vin and Prof. Figan have said?
Absolutely, both of them are a great question. I want to quote the paper which was published a few years ago from Netherlands, around 308 patients who had a recurrent pleomorphic adenoma. They have actually assessed the true spillage as well as microscopic positive margins. Actually, they found there is no difference between those two. And they also argue that we shouldn't be routinely giving post-op radiotherapy for spillage. I think they say clearly maybe 2% increased rise when compared to microscopic positive margins. So my answer would be no post-op radiotherapy, unless if it is come back second time you're doing surgery, you might consider or discuss that with the patient.
Okay.
Regarding the post-operative, how to minimize the risk. Yes, I think I prefer to do the MRI scan for all the parotid cases because you need to start this before the operation. So if it is bigger or involved in the certain kind of trunk area, so you can plan the operation very well. So it could potentially minimize the risk in addition to those mentioned by both like tissue handling and retractions and all these things. Sometimes you may have to modify your approach. Retrograde dissection might be another idea. If you think you're going to stay around the trunk that could cause potential spillage, those are two things just I want to add.
Okay, so I think we've got some consensus is that. So Guri, I'm going to ask you a couple of questions that have been brought up by the by the audience. So the first one was Ali Alami, which basically asked, what is the benefit of the scanning mode in the CO2 laser?
For me, the advantage is you can paint the shape that you want to cut. You can have a straight line, you can have a curve, you can have a circle, and you cut over a wider front. You can change the length of your cut. So you don't have to keep moving the spot, because not traditionally we would follow the line of cut with the spot and the joystick. It just makes life easier, a little bit quicker. But there's no reason you should have to resort to it to be competent in laser laryngeal surgery. I mean, for the first 15 years, I pretty much used the spot alone. Okay, that's great. And the second question that was brought up for you was, can the venturi ventilation can be used in the post-COVID pandemic era? Yeah, this is a tricky question. because I have a large airway practice which carried on during the COVID era. And it is very difficult to get your face to a microscope with some sort of eye protection or visor or anything else. So in the end, we resorted to testing all the patients as much as we could, no tests 100%. So we were taking a bit of a gamble. Obviously, we had PP3 masks, and when we could, we had visors. But there was no easy option. If you had patients that were struggling with their airway, you had to do something.
Yeah.
So it's a difficult one, and it's a personal choice, really, because there is a risk.
I mean, of course, with everybody kind of testing patients, that degrees of exposure is potentially kind of minimal. Certainly, we did all our patients with through a green corridor, and Vin, for instance, did all the Marsden kind of patients had the same sort of kind of thing. I mean, did you experience? I mean, we all had to kind of do laser cases at some point for small laryngeal cancers or biopsies and so on. So I think it is really a problem. But I think everybody gets more panic than the actual surgeon and the anesthetist. So it's actually the nursing staff and the theatre manager who's basically going to, not than kind of the actual surgeon is probably going to say, well, we've got to get it done really. But what do you guys think, Vin?
Yeah, but it is an awkward one. We, as you rightly said, we paused operating for a short while at the Marsden at the peak of the pandemic crisis. Then we went back to the drawing table, got all stakeholders around the table, the nurses, the managers, the anesthetists, and came up with a unique SOP for the COVID era. And this involved adding in an additional suction kit that killed 99.999% of the viruses and taking additional precautions. And we cracked on. But I'm pleased to say that there weren't many theatre personnel getting infected. So I think we worked around it. I take Guri's point. It is risky. Nothing is ever completely free of risk. Hopefully those days are behind us, because we all have had, in the UK at least, the first dose of vaccine as frontline workers. I don't know how things are in other parts of the world.
Yeah.
But apart from advising you to take very good care, I can't think of it. I'm happy to share our SOP if you want to, for operating in the COVID era in the airway.
Yeah, no, we had the same sort of thing. Johan, what's the situation in South Africa regarding kind of laser cases and the sort of high risk patients with or high risk kind of procedures, really?
Yes, thank you. Well, we test all our patients, and they have to be tested within 3 days of the procedure. Otherwise, we won't allow them into hospital. That's the first thing. And then I wear N99 as a respirator while doing any airway surgery. In fact, I use that for all my surgery, and I use and I wear eye protection routinely. So that's been my drill. Yeah, and I've had my J&J vaccine. They just started vaccinating the doctors and the healthcare workers, but it's going to be a long time before we're going to catch up with the UK. It might be a year or two before we actually reach herd immunity levels. So we'll have to be cautious for quite some time to come.
Yeah. Jay, what happened in Scotland? Did Nicholas Sturgeon sort of tell you things differently?
Yeah, we slightly do differently. We just change our practice according to the prevalence of the area. And the hospital is coded 1 to 4. 4 is the kind of highest red alert. And if anything below 3, we are allowed to do laser cases, but we do practice 14 days of isolation and COVID test day 1 and day 40. And they get admitted in the green zones, which is actually a COVID-free area. And while doing the laser procedure, we always use full FFP3 for all the staffs and a limited number. That's what we do. And in other areas, less, if the number goes down to 2, possibly we have only 7 days of isolation. We don't do 14 days of isolation.
Okay, thank you. So I was going to ask obviously because yes.
Sorry, Ricard, Farouk here. Can I just quickly ask you guys?
Oh yeah, something? Great. Okay. Did you manage to get up? So you've been to the toilet, we're all sorted now. Thank you very much. Thanks for joining us.
No problem.
That's brilliant.
No problem at all. It's a pleasure. Look, I just wanted to ask you guys if what was your experience with negative pressure theatres? I mean, in Australia, we've had this model COVID control where essentially community transmission was brought down to zero. The government took an eliminationist approach, and essentially we've had no COVID in the country for almost 3 months now. And even prior to that, it was very minimal. We used N95s. ENT was moved to a negative pressure theatre in pretty much all the teaching hospitals. The use of Thrive was completely stopped. Where possible, closed circuit ventilation was done for laryngeal cases. So we went back to MLT tubes where possible. And we were strongly discouraged from using laser unless it was required because of that risk of vaporization. There was a period of time where radiotherapy was used instead for biopsy-proven early laryngeal cancer because patients may need a second visit, a second look procedure, and so on. So staff exposure was minimized. But yeah, I mean, that was quite a hardline approach, right or wrong, we don't know. But as community transmission went back down to zero, we went back to our original practices with the appropriate PPE still. And now, essentially, the Pfizer vaccine's been rolled out for the frontline workers, including ENT.
Great. No, I think, do you want to ask, so Johan, what did you, negative pressure theatres, did you have access to them?
Yes, we did during the peak of the pandemic. We had a special sort of COVID theatre in the hospital, where we took any patients that were, where the COVID status was unknown, and where we did all our airway procedures. And of course, we see a lot of, we've seen lots of patients coming in with airway compromise, with advanced laryngeal cancers who haven't been able to access care over the past year. And so our registrars have had to do emergency tracheostomies often awake in patients where the COVID status is unknown. So they have to take full precautions, and we put them into a special COVID theatre.
Yeah. Vin, negative pressure theatres or not at the Marsden?
The concept of having an anesthetic room was taken away, so patients went straight to theatre where the turn change was quicker. We didn't particularly go for the negative pressure theatres. The change was quicker in theatres, so that was used for intubating and for putting the patient to sleep.
Jay?
We do use the negative pressure theatres. And the second thing is about the evidence. Unfortunately, there is no evidence there. I mean, currently there is only 3 papers, like the COVID surge and COVID cancer and Richard Shaw's Liverpool papers. We have very limited number of head and neck cancer patients, only 1,300. Not most of them are like kind of proper head and neck non-aerosol generating procedures. And the laser procedures numbers are very low. But having said that, in 9 wells, and the IT department monitor the local green zone area, and we found there is no increased incidence of infection to the staff members or the patients who is kind of, they're monitoring the hospital-acquired infection. So we didn't stop, but we did stop for only 3-4 weeks.
What about you, Goreen, Charing Cross? What did you have?
We didn't really have access to negative pressure theatres. We did a procedure and we let the theatre sit for a couple of hours and did the next procedure.
Yeah, we had a very similar approach to the Marsden. So we had a kind of basically a green kind of pathway, which was at Guy's HCA within the campus of Guy's, and then we had an amber kind of theatre where we would do it at Guy's. So we had 2 separate pathways, but we didn't have access to negative pressure theatres. So I was going to also kind of ask, because obviously there's no kind of the opportunity for the audience to ask questions except for the chat. And I think it'll be probably unfair not to ask anybody about a specific question about their talk. I was just going to start with Vin. Unfortunately, Karsten is not here, and he had a really fantastic talk about parapharyngeal space tumors, which is really something that I heard before, and he's just this really puzzles me, the amount of kind of detail that is really put on that. But Vin, I mean, your lecture was just really phenomenal. Really is fantastic, and thanks very much for using me an example and sort of bringing my kind of sexual experience of theoretically I should have had about 6 sexual partners according to your assumption. So, but anyway, I'm not going to kind of say that anymore. Anyway, I was just going to ask you about the robotics kind of surgery. I mean, obviously you were kind of a great robotic promoter, but I think people have, especially in certain countries, actually pushed the boundary of the robotics. And obviously, there's no question that the robotics done, in a cavity like the pelvis of the abdomen or the chest has been a really, really great kind of advance. It's really minimized the amount of pain and increase the recovery. Obviously, in the oropharynx and larynx now, there's no question there's actually a really significant advantage. However, I mean, there is a kind of a few kind of areas in the head and neck which we still we don't really know whether that's the kind of endoscopic kind of robotic approach is going to basically succeed. And one of them is actually the parotid. The other one is the thyroid. Is still very controversial. The other one is basically the use of this technology in the neck, doing neck dissections. What do you think is the direction of travel is that in that regard?
So there is thank you for your question, and thank you for letting me use you in my talk. I wasn't making any assumptions and extrapolations as to your history.
But it's a great example. Thank you. I really appreciate it.
So we have there's a distinction to be made when you're using the robot for thyroid, parotid, neck dissections versus you're using it for larynx and oropharyngeal tumors. Because on one side, as in the case of laryngeal and oropharyngeal tumors, you're actually avoiding open surgery and truly making the surgery minimally invasive in those instances. Like when I take out a recurrent tongue-based tumor with the robot, I'm actually avoiding a neck dissection, a mandibulotomy, a free flap for its purpose. But when you're using the robot for thyroid surgery, you're actually turning something that is minimally invasive using a 4 centimeter incision at the front of the neck into a maximally invasive procedure where you make a large retroauricular incision and work your way all the way down to thyroid. So the sole advantage of using the robot for these procedures is to avoid a scar. If your patient hasn't got a great problem about the scar, then the whole need for robotic access has been abrogated by that. So that's a choice any department has to make. And certainly in the Far East, there is a societal pressure to try and avoid a scar, and we get that. And the physicians support that societal pressure. That doesn't exist here. So I can't, in my practice, make a strong case for that until we generate appropriate evidence to deliver on this within, let's say, a controlled clinical trial where we generate the data. Whereas the situation is completely different for cancers.
Yeah. Anybody's got any different views about what Vin said? We agreed. Johan, you're going to say something.
Could I just comment on Vin's talk? I mean, it was a wonderful sort of presentation. But to me, coming from a developing world, where we know that 70% of head and neck cancers occur in developing countries, and we know that in South Asia, only 3% of people have access to safe, affordable surgery. Clearly, the challenge is on the way, on the one hand, to push the boundaries and the frontiers, but the biggest challenge is how do we make that kind of technology appropriate for developing countries? Because if we want to make an impact, if you look at a global head and neck sort of cancer deaths, then we have to make a change in developing countries. So, Ben, I'd be very interested to know what the prospects are for this kind of technology, that you've spoken about, to actually reach developing countries, and are people working on that aspect?
So if you're talking about technology, Johan, certainly it's getting cheaper and cheaper. The The Society of Robotic Surgeons meeting didn't happen last year, but the year before it was held, and I went along for that. I was truly impressed to see the number of surgical robotic systems hitting the market. These systems are getting more and more task-specific. They're certainly getting cheaper. It's quite a long haul from a system hitting phase 1 trials to getting approval for use in humans. So that's quite a long haul. But certainly from a futuristic perspective, you're getting more and more task-specific systems, and the only way it is going to get cheaper because there are more competitors coming on the market, and competition always drives the price down. As regards to use of robotics in deprived settings, I get it, it is a difficult discussion to have. On one hand, we're trying to push the envelope here. On the other hand, we have difficulty in even assuring basic care for these head and neck cancer patients, and that is something each government has to take head on, and then discuss finances and decide how they're going to spend the money. So that is something that is a difficult discussion to be had within different countries.
Thank you. I was going to go to the kind of the next talk, which is obviously the thyroidectomy, and obviously it was again, for focusing on the developing countries, and in a way your approach is basically very much kind of basically based on your really, having really good clinical expertise, and also doing safe surgery. And sometimes what we feel is that basically doing safe surgery, certainly in the parotid, means that you always have to, in order to avoid you having to kind of have a problem, your surgery is going to be, although now we're trying to kind of de-escalate, procedures in terms of kind of, extracapsular dissection parotectomy. In a way, you have to kind of basically do a much more, you have to do an oncological operation for every single parotectomy, or not, or am I kind of, perhaps I didn't really read that kind of well.
So am I getting it right that the more conservative your surgery, the more extensive your investigations have to be? Is that what you're saying? So you don't do the wrong operation for the patient?
No. I mean, what I'm trying to say is that we're trying to kind of de-escalate, and then again, you probably by wanting to de-escalate, you're trying to kind of have as much as clinical information and radiological information before. Whereas you are, in a way, you kind of, if you are restricted by this resource, then your surgery's got to be much more safer in a way. Because what you want to avoid, spillage, you want to avoid, having to, avoid these patients having radiotherapy. You want to avoid these patients having kind of an extra procedure because you have a kind of a positive margin, et cetera, et cetera. That's what I on. So in a way, in a way, your approach kind of it kind of limits your that the escalation that sort of kind of the Western world is trying to do.
Yeah. Well, realistically, even in my center, which is is a wonderful center, I mean, we have limited access to cytology and to frozen section. We just don't have and to MRIs and CT scans, and so that's the real world. And so because this is a global sort of program, I think it's important that we don't only talk about the first world sort of picture. But essentially, my view is that if you have a clinically benign tumor, then you can do a partial parotidectomy. You're taking out a lump with the surrounding tissue, and then you have to wait for the pathology. And it's very, very rare that even if it's a malignant tumor that you have to go back and do more, provided that you have postoperative radiotherapy facilities.
Yeah.
Of course, if you don't have postoperative radiotherapy, then that opens up a whole new kind of worms as to how do you manage it. You have to go back and be more aggressive surgically.
Yeah.
But that's the bottom line. So I do think there are many investigations that we often do that really don't change our management of from a surgical perspective.
Yeah, I mean, it's interesting that you said that, because obviously that's, and Vin will probably remember that from the days we were actually with Pat Bradley Nottingham, and that was his philosophy really at the time. He didn't really over-investigate, parotid tumors. He was saying, okay, it feels like, superficial, it looks like it's a pleomorphic. Why do you kind of do a scan? you got to really take it out. And interestingly, his results and your results, basically based on that approach, are not actually dissimilar from kind of the really the Western kind of world kind of rate of recurrences. I mean, your local control is 93%. So in a way, that's not. In a way, it doesn't look like it's actually much different, or that difference is actually really quite marginal. Is that right? Is that what you?
That's absolutely. That's absolutely so. And if you think about it, most parotid tumors are actually very well defined. It's only the very nasty tumors where you have soft tissue infiltration of the surrounding sort of area. And so the debate often comes up. What about the deep lobe of the parotid? You have to take it out because there might be lymph node metastases there. But there again, too, we know that the results of managing the N0 neck in parotid tumors with radiation as opposed to surgery is very similar. So if you're going to be radiating a high-grade tumor from the parotid area, then you're probably going to control those occult nodes in the deep lobe anyway. So it's a very conservative approach, but it seems to be borne out in practice, and so I'm very comfortable with it. But I'll once again be very happy to hear opinions from the other panelists.
Yeah. Farouk, do you want to comment on that?
Yeah, look, I think I completely agree, but I do think you need to realize what the local community prevalence of whatever the pathology you're dealing with is. Look, for us in parotids, as you know, metastatic SCC is probably the most common lesion we see, with no primary cutaneous index lesion visible in over 80% of patients. So there's absolutely no doubt that they all get an FNA. I think that's important for us because we need to consider whether these patients need a neck dissection, which is pretty important in cutaneous SCC. Primary parotid tumors, as in malignant primary parotid tumors, are very rare here. I'd say over 80% of malignancies we deal with by far is metastatic cutaneous SCC, sometimes with or without a temporal bone resection. So I think for us, imaging is absolutely vital because we want to look at things like perineural invasion, which is a very important prognostic factor in the pathology that we deal with. The fine needle helps us to prognosticate the neck. It helps us to plan adjuvant therapy. It helps us to plan the management of the facial nerve and including potential counseling of patients in dealing with scenarios of nerve encapsulation, nerve invasion, because if you didn't know what you were dealing with, then the intraoperative decision becomes, the nuance of that becomes that extra step more difficult. And of course, knowledge of the anatomy beforehand. I think it's very different if you're dealing with a small, mobile, inferior pole tumor, then yes, all of those clinical parameters apply with the caveats that there has to be a pathology-driven process.
Thank you. I was going to, because obviously I've got my first slide here, but I was going to kind of try to kind of do a case or a couple of cases that we can all kind of, dip in terms of kind of comments. So I have, well, I've got quite a lot of cases, but I will probably kind of focus on, in the interest of time, just focus on two. So this is a 75-year-old lady who, yes.
Before we move on, there's an audience question about parotid. Shall we take that and then kick off with the cases? And that's the only question on parotid.
I didn't see it. Sorry. Yeah. Is there one?
Yeah, so the question is, what would the extent of parotid surgery be for malignant high-grade parotid disease in the context of an intact facial nerve? Would the management of the facial nerve change if the patient is younger or older? So that's the question. So high-grade tumor, facial nerve is intact, younger versus older patient, would the management of the facial nerve be different? My answer is no. I would crack on and save the nerve whenever I can, irrespective of margins. I don't know what the others think.
Agree.
It's safe. If the nerve is working preoperatively, you have to take every step to preserve the nerve. And most likely, this patient is going to have adjuvant radiotherapy. So I think that's reasonable, unless during the operation, if you find it, you can't resect the tumor and you're going to leave gross disease, it's worth removing the facial nerve. But this all needs to be discussed before the operation. So it's worth involving sometimes a plastic surgeon if you're not comfortable to do the nerve anastomosis or grafting, or even some extent otologist if you're struggling to find the facial trunk, you may have to drill the mastoid to find the vertical part of the facial nerve to get extra length. And it's worth getting a histopathologist on board. Sometimes you may have to use a frozen section as well. But post-operative radiotherapy, will it affect the graft? Actually, there is no evidence. It doesn't really affect. Sometimes you may have to consider really old people. The nerve is a bit longer. You may have to consider reanimations. Sometimes you have to use a facial atlas-link, or sometimes you use the temporal lobe. Temporalis muscle, which can be rerouted to the eyes and lips, but that needs extensive training with a plastic surgeon as well. So a lot of things needs to be discussed.
Farouk, do you comment on that?
Yeah. I mean, look, I think most of these are established guidelines where the facial nerve is working. Yep, definitely try and preserve it. I'm not sure if there's any evidence, even in high-grade tumors, if the surgical capsule, which is a surgeon-determined completion of the parotid resection, is complete, resecting the facial nerve gives any extra benefit to either disease-free survival or overall survival. I think most of us add in adjuvant radiotherapy in that scenario anyway. Ductal carcinomas, which are the really highly aggressive parotid malignancies, I think they do badly regardless. High degree of local recurrence, whether or not you radiate them, I think that's biology driven rather than the surgical aspect of it.
Mm-hmm. Good. So, Vin, if you don't mind to kind of keep an eye on the chat, because for some reason as I'm sharing the screen, I've got the full screen and I don't have the chat appearing. So it'll be great if there are any other questions, please highlight them and or anybody, and then we can go through it. So this is the case. Hopefully everybody will be able to comment. Sorry, say it again.
I had one question for Guri, which is it's a burning question. May I quickly ask that, and then we can move on?
Yeah, no, absolutely. Yeah, no. I've got quite a lot of few burning questions for everybody, but well, anyway, that's fine. Go ahead.
I'm sorry to put you on the spot, Guri, but this is nothing. Cool. So, Guri, anterior commissure web after a laser surgery for a glottic tumor. I don't tackle anterior commissure tumors yet. For the anterior ones that we resect and do a type 3 recurrectomy, you get a small web coming. It's an annoying complication, really knackers the voice. What do I do with that, Guri? I'm very happy to send them to you. What do you do with them?
So the problem is that you've knackered the voice not because the web has formed. That's part of it. Part of it is you removed the vibrating edge for the extent of your resection. The third bit is that you've affected Broyle's ligament.
Okay, yeah, I have.
You've introduced laxity because you've just excised all of that, yeah?
Yeah.
So, yes, you could take away the web and it would look anatomically great, but the voice would still probably be pretty rubbish.
Yes.
Yeah? So it's not an easy one. And that needs, and I remember you and I having this discussion at a meeting many years ago when you were leading and putting a video up about a T1B. And I was the one that said, look, if it is a professional working person, I would give them radiotherapy. Just because I'm clever with the laser isn't necessarily indicated. But I'll give you a counter argument now, and this comes from experience. I now have patients who are professionals that I didn't laser that were very easy lasers, lawyers and city types and this kind of thing. And you thought, well, if I laser this and give them a rubbish voice, then I'm going to get sued down the road. I now have those patients come back with a little, a T1 radiotherapy window. They're coming back with dysphagia and dysfunctional larynges. So, this is 15, 20 years later, and I'm thinking, perhaps I should have emphasized that a bit more. So it is not easy. It depends on what stage in your career you're at.
Yes.
But I'm doing about turn now, whereas I was saying, well, actually go with the radiotherapy.
Yeah, it's interesting. I think all these late toxicities, that's another, we could probably have a round table, because it is really fascinating the way that now the more that the patients live, the more you see really odd things as you go along. And I'm sure we all kind of see that. I mean, and that's a kind of a really similar case. So this is a 75-year-old lady, and this is not a malignant tumor, not a malignant case, but so basically, as you can see in the picture, there is a pouch here. So this lady is otherwise fit and healthy. She's the mother of a friend of mine who was actually from my triathlon club. As a matter of fact, she said, I had this, and when she knew that I was basically doing this sort of kind of surgery, she's asked me to see the poor mother. So basically, this poor lady had 2 endoscopic approaches, 2 staples, and then they were failed, and then she had an open approach. And the woman was 70. Well, she's 75. She is very, she wanted to go out to her friends and sort of kind of eat. And basically, she came to a point where she couldn't really eat. She was completely dysphagic, and she became a social outcast. And that was obviously before COVID. And the poor lady was extremely frustrated, and the quality of life and mentally, she was really, really. Quite problematic, really. So, what sort of kind of approach would you guys kind of, do? Guru, you mentioned earlier about the kind of the laser for kind of.
Can I take a step back here with this case?
Yes.
What, in the history when you first see her, whoever saw her first, what was the history? Was she having swallowing problems, or was she having principally regurgitation?
Yeah, I don't know. I mean,
that's just it. So people will investigate swallow, and they'll probably do a barium, and they'll see a pouch, and they'll assume that the dysphagia is entirely related to that pouch. The pouch is there because there are other problems. And in this age group, there are usually multiple problems. So people make the assumption it's the pouch and work on the pouch. You need a proper assessment, a proper history, a proper assessment. You need video fluoroscopy. You need to look at it carefully, because the number of times I've done pouches and the benefit, if any, is marginal. Is too many to mention in this age group. Yeah. The other thing to say is, in this age group, if you damage any mechanism, any part of the mechanism of swallowing, pharyngeal plexus, tone of this muscle, that muscle, they have very limited plasticity. Yes. A 40-year-old has plasticity. These people have no plasticity. So when you do a pouch stapling, one advice is don't go back and do another video swallow or a barium swallow, because it always looks rubbish. Okay? And then you assume that, it still looks rubbish. The pouch is that I have to do something else. And as soon as you open the neck up in an elderly patient, you disrupt the pharyngeal plexus. So even if the operation looks good on a barium swallow afterwards, they may still have difficulties because you've now damaged their swallowing mechanism further. So often they're worse. So I don't necessarily jump into an external approach. The thing to do is go and reevaluate the patient. There's probably a lot more going on than this pouch alone.
I mean, this lady had a kind of basically the whole thing stem about 10 years earlier. And obviously I didn't really have access to that specific history, nor to the surgeon who did the surgery or the previous barium swallow. So she had an obvious pouch on. She was dysphagic, and she was regurgitating as well. But she primarily had dysphagia, and then she was really troubled. She was basically a social outcast. So I mean, the approach here, you got 2 endoscopic approach, 2 staples, and 1 open approach. What do you actually do?
Reevaluate.
Yeah, and so what is your reevaluation kind of approach here?
So I mean, all right. So if her only problem is the pouch, which is highly unlikely, she's probably got some tongue weakness, she's probably got some pharyngeal discoordination, and she probably certainly has now that she's had an external approach. So there are going to be a number of issues, and what I would do is see how many of those issues can be assessed by decent swallowing therapy. Ultimately, your only option with this is going to be endoscopic, if it is the pouch, because I don't think going on, I wouldn't risk an external approach again. You'll just make things worse.
Yeah.
And the question is, what do you see, and is it amenable to some other technique, different stapling, or maybe laser the ball, that kind of thing? But you've got to go carefully.
Yeah.
Because there's a big risk.
I totally agree. Anybody has got any comments about this? I'll tell you what we did.
Can I comment? So my experience, when I'm doing revision cases endoscopically, often there's a thick scar band around there, and you still see the old staple sitting there. And I think the success rate of restapling is often very poor. So I think you have to be fair to actually excise that whole scar band with laser. Otherwise, I think your outcome of doing an endoscopic procedure is really going to be probably quite poor.
Yeah. Jay, what do you think?
Yeah, I mean, this case you correctly mentioned is arthritis, and that sometimes limits the neck extension. So maybe the first two procedures with the endoscopic, they might have kind of some struggle. It may be inadequate kind of stapling might have been done. I mean, in Scotland, especially in my area, we do carry a lot of pouches because people live longer, average age of kind of 89 for us. It's not unheard recurrences after endoscopic approach. Considering this patient, as Guri said, we re-evaluate the patient. And also sometimes acid reflux might be causing the same symptoms. We do treat them first. We start with some anti-reflux treatment, whether it makes it better. But if there is still persistent symptoms, I would evaluate this patient and in theater, go with an open mind for repeated endoscopic stapling. If that fails, if the approach is not good, I would consider a transoral laser as well. We have a specialized endoscopes for transoral laser as well in case if the Vieda scope is not getting the correct position. And open approach is, we do consent them, plus or minus open approach. If we are planning open approach, I do use recurrent laryngeal now, like thyroid monitoring one. It does help because one of the complications is recurrent laryngeal nerve palsy, especially when you carry out correct thyroidectomy, which is myotomy, which is very important to prevent recurrences. Even the pouch cases with endoscopic approaches, the only drawback is sometimes you don't divide the cricopharyngeus muscle, which is a circular muscle, which is responsible for kind of preventing the recurrences. But this is the post-op view, that's immediate pre-op view. It is sizable pouch, I would say, a large part of intervention.
Farouk, do you have a comment on that?
Yeah, look, we published on this a few years ago. I don't think if they've been stapled twice, endoscopic procedure doesn't necessarily mean stapling. It could have been harmonic scalpel, it could have been laser. But I think if they have been stapled, further stapling doesn't work. You get a staple line over staple line effect, and the second staple line does not engage adequately. I agree with Guri that if you basically provide endoscopic treatment, you're not treating the sac. So further barium swallows will always show the sac, at least part of it. And so I think you need to work out if the symptoms are dysphagia, which is largely muscular, or if the symptoms are regurgitation, which is more sac-related. We would endoscopically assess the pouch, pack the pouch, and go externally with a nerve monitor, as Jay suggested, simply because I don't think a third endoscopic approach, assuming that the first two have been done adequately, would be enough.
Yeah, I mean, I agree with what all you said. And then we did have a kind of basically multidisciplinary approach with the speech and language therapy. She had the fluoroscopy, she had the pouch. So what we end up doing was basically just you can see the kind of the bar, the scarring, and then so we did a laser excision, and she still had a lot of kind of fiber. We had to kind of basically be very, very, very careful. We obviously did consent her for an external approach, and she was the mother of a kind of a friend. But anyway, this was done 2 years ago, and she's been fine. I mean, I only saw her once once after the surgery. She was absolutely fine. She was delighted, and hopefully she'll stay the same. So that's basically what we did. So and again, when we did, I mean, there was a lot of charring here, and it looks really horrible because we had to kind of keep cleaning it. But I kept sort of kind of basically taking staples, with a laser. So there's a lot of firing kind of up and down. But she did extremely well. So yeah, I think all you said is actually all very valid.
Ricard, can I just add one thing? Sorry, I forgot to mention earlier. Jay commented on recurrent laryngeal nerve palsy.
Yes.
Can I just say that that's been described after endoscopic approaches as well with the stapler? We've had a couple of medical legal cases locally, and more so in the revision scenario, because you get a lot of cicatrization, which actually rotates and brings the laryngeal nerves more posterior. Compared to how we always assume that it's much more anterior. And so if we go to the back, it's okay. That's not necessarily the case. The other thing is sometimes in a difficult case, as you engage the stapler, you're not actually completely in the midline. It might appear in the midline, but the esophagus is actually rotated. Yeah.
Sometimes what I found is that in these patients who are osteoarthritic, is that if they have anterior osteophytes, you cannot really engage the stapler kind of, flips over the osteophyte. So you cannot really engage it in the midline. Also, one of the things that this actually happens with the endostaplers is now, for some reason, certainly, I don't know, you guys in the UK, you have the same problem, but we cannot really get, the 35 millimeter staplers. We only have the 45 millimeter, but I find them extremely clunky and very cumbersome to try to kind of get into a potentially quite a difficult airway or kind of upper esophagus.
The other thing that's quite useful is the laparoscopic harmonic scalpel.
Yeah.
I mean, the way you've got it exposed, it's ideal. It's a one shot with the laparoscopic harmonic scalpel.
Yeah. No, that's a really good tip. So interesting case. Anyway, I'm going to, are you guys okay for another case? And then we'll probably close it. Is that okay? So what we are going to do, I'm just going to go to we already kind of discussed quite a lot of this, but I'm going to, because I kind of think Guri is here, try to kind of get him engaged. I'm going to go to kind of basically a revision case. So this is the case that we just did a few weeks ago. There's a few aspects on the kind of management of this patient. So 60 years old, he was a jazz vocalist, blues band, quite a guy, very, very interesting character, heavy smoker, is also smoked marijuana. Basically in 2018 had a transglottic T2 of the left vocal cord treated with radiotherapy. He's got hypertension. His ischemic heart disease, but it's relatively well controlled. His performance status is actually pretty good, and he still kind of really smokes. He continued to smoke through radiotherapy, and and continued to smoke after the radiotherapy. Drinks about 21 units of alcohol a week, and he lives with his wife. So basically, he presents. This is the picture. That we had when he presented. He presented in March last year, basically in the middle of the pandemic. So he had a panendoscopy. His airway was obviously, as you can see, pretty compromised. And I was just going to ask Guri, in terms of basically kind of managing this airway, what would you do when you're actually in theatre? A part of, you can do obviously a lot of kind of debulking, but what would be your kind of main preference of debulking this patient to try to give this guy a safer airway?
Okay.
He was very, very adamant that he didn't want a tracheostomy in the first place.
Can you just describe what it is we're looking at here? Is that the glottis?
Yes, sorry, beg your pardon. Yes, sorry. That's the tube. That's the endocritical tube. This is a microtube. Yeah. So on the left-hand side is basically a transglottic tumor. Yeah. You can see it in here. That's the kind of the laryngeal ventricle. This is the right-hand side. This is the left-hand side. And this is basically the kind of a very precarious airway with a very locally advanced tumor. It was initially a T2, clinically is a T3. Obviously, there's a lot of kind of laryngeal edema from his previous radiotherapy.
So the question is, how symptomatic was he with his breathing before he went to sleep?
That's a very good question. So it was actually quite all right. So he had kind of a kind of mild audible biphonic stridor, but it was not. He could kind of basically walk and go up and down stairs, but he was, typically it was audible.
Okay. Now, the most important thing here is when you're putting someone like this to sleep is to have a plan with your anaesthetist before you touch the patient.
Yeah.
Because you need to have options should things go wrong. Are you going to use Thrive? Are you going to use a transtracheal cannula? You certainly should have an emergency tracheostomy set on standby. So all of those things are important, and people get in trouble when they haven't got a plan beforehand.
Definitely.
Ordinarily, if this was a first time, I'd say just carve it out with a laser, just follow it around, and you'll have a better airway. But you have a post-radiotherapy neck.
Yes.
And the factor here that adds difficulty is all that edema. All that radiation damage and radiation edema and scar and everything else, which makes things difficult. So you're going to have to go pretty wide to clear that, to have a reasonable airway afterwards. Yeah. And then the impact on his swallowing and everything else, which will already be impacted because he's had radiotherapy. What sort of tumor is it?
No, well, let me just explain. This was done in the kind of the HCA theaters. We didn't have a laser at the time. It was in the middle of COVID, so we were going to. I mean, it was obviously consented for a tracheostomy. We had unfortunately we did not have kind of airway anesthetist, but we requested one for that specific case. So we had a plan, A, B, and C, and I think that's all been really taken care of. The question is, you see that, and then what's the?
What would I do? I'd probably replace that tube with a Hunsucker. You're not going to easily be able to supraglottic jet, and then I would start lasering away that tumor. Protect the distal airway with a patty below if you can, and just debulk, and see how it looks. Yeah. But the important thing is, even when it looks good when you finish, you've taken enough of the tumor away, and you think that's a reasonable airway. Do not be surprised that as you try to wake the patient up, that the patient is still in difficulty. That transition from being paralyzed to being awake and breathing spontaneously is the most challenging bit. Yeah. Mm-hmm. So even if you think you've done a good procedure, do not be surprised if you then still have to resort to tracheostomy. If you have a really clever anaesthetist, they'll be able to put positive pressure support and maybe get the patient through it. But this patient, debulking, I mean, you're not going to go curative there at all. Debulking is just to buy a bit of time. He's going to end up losing that anyhow, isn't he?
Yeah, eventually did. But I'll tell you the story, which is really a true story. But anyway, any other comments about, I mean, obviously we didn't have laser.
Microdebrider you can use.
Yeah. So
have reduction diathermy handy.
Yeah. So that's exactly what we did. So Jay, you put your hand up.
Yeah, in this case, I mean, I won't be able to use laser if it is out of hours. We use the laser safety officers and all these people are needed. This particular case, I would use a big biopsy process, particularly upturned ones, and try and kind of remove as much as possible and create a good airway and use a suction monopolar that actually gives you a good hemostatic kind of area, then keep them in the intensive care unit. Then, I mean, I would persuade him for tracheostomy, or sometimes if the patient is not happy to go ahead with the tracheostomy, you have to accept the fact. I would try to review the scans. Is there any scans done before?
Yeah. I mean, basically, that's what it showed. So basically, there was no, there was a transglottic tumor, but there was no kind of evidence of any extralaryngeal extension at that point.
So that's what I would do at this point.
Yeah. Anybody, Vin, what would you do? What sort of kind of instrument, what would you do for this?
Yeah, it's a tough one, isn't it? As Guri said, it is post-RT. We looked at this very carefully a while back, and supraglottic tumors, they are good for debulking. You get durable control if you debulk supraglottic tumors. I would look at a scan very carefully. If a scan shows paraglottic space invasion, if a scan shows significant edema and infiltrative disease, you can debulk, but he could be in trouble very shortly after that, because for whatever reason, the swelling comes back and the airway gets compromised. So I'll be very reluctant to even discharge him home after debulking if there was paraglottic space invasion on this post-RT setting. But if he hasn't considered for tracheostomy, even after good debulking, I've been in a situation where the patient wakes up, they seem okay, they got stridor, they go to recovery, and then they decompensate. They're back in the theatre again for repeat intervention. So you've got to consider for a tracheostomy. But he's going down a total laryngectomy plus free flap augmentation in my hands.
Yes, Johan.
Yeah, I haven't got much else to add other than we must also just bear in mind, could this be chondroradial necrosis that you're dealing with? And so the question is, how aggressive should you be with your debulking, so not knowing what your pathology is at this point?
Yeah.
But I would use cold steel for it. I would just and I try and avoid a tracheostomy because it just makes the subsequent surgery more difficult. So if you can avoid it, that's good. And tumors at this level are less of a problem, so making the patient tumors, which where the airway is less predictable when you're reversing the patient's anesthesia.
Yeah. Farooq, you've done a very good talk on salvage laryngectomy. What do you have anything to comment on this?
Yeah, look, I mean, for the purposes of debulking, I think I would go for microdebrider or coblator. Laser takes a long time with this. You don't know your distal destination, so you're kind of just burning down a tunnel, not knowing where it ends at the other side. So it's quite and then you have to use a slightly defocused beam to get the tumor vaporized. It's time consuming. You need laser staff, and it's you're not going for a precise excision here. You're basically reopening the airway. Absolutely no doubt, having tried all these approaches, I think the coblator LW wand is rapid. It's effective. It will literally vaporize through. It's now used in sinonasal surgery, airway surgery, larynx. Not the MLW, which is for finer excisions, but the LW wand would literally vaporize and recreate the airway for you. All the other caveats of the tracheostomy still apply, but for the debulking, a microdebrider or a coblator would be far more effective.
Yeah, absolutely.
Ricard, there are 3 questions from the audience, okay? Just to remind you, so you're aware of that.
Yeah, I'll just go through quickly with this. So this is basically his scan. We did manage to. So isn't really. So it is quite bad to start with, but anyway, that's pre-op or pre-debulking. And the debulking, as I said, we didn't have a laser because of kind of COVID. We had it in a kind of a green kind of pathway. So we had a combination of basically manual debulking, cold steel, and microdebrider. And obviously had steroids. We had a kind of basically a plan. He was woken up. He was very anti tracheostomy. So we did, discuss him at the MDT, and obviously the recommendation was, and I think you already mentioned, Vin, that this chap would need basically total laryngectomy, and I think there was no question about that in anybody's mind. Anybody had any comments, or would you do anything differently? A part of basically a total laryngectomy with a free flap? No. Anyway, so
I wouldn't do a neck unless the PET scan and the CT showed clear evidence of neck disease.
Yeah, so we can absolutely. So that's something that we will obviously we can discuss really further down the line. So the interesting story about this guy is that we only did the laryngectomy 2 weeks ago. That was in March 2020. So basically, this guy refused a laryngectomy, and then he had 2 subsequent, debulkings because he was very adamant he didn't really want a laryngectomy. And eventually, just before Christmas, turned up, his airway was critical, and it was so bad that we had to have a laryngectomy. A tracheostomy. So we eventually, he consent really to that. So And in terms of the, we obviously the questions here that they occur is obviously we already discussed the issue about the thyrodectomy, the issue about the necks, the issue about the prosthesis, and to whether you will do something that's actually straightforward free flap reconstruction, or you would do actually something pretty different. So thyrodectomy, what is interesting, you haven't seen in the scan, but he had a kind of an agenesis of one thyroid lobe. So he had a kind of, and that was unfortunately the ipsilas, the contralateral side of his tumor. So we had to take his thyroid lobe out because by then, nearly 9 months down the line, the tumors actually came out, through the parapharyngeal space, into the paraglottic space, and into the back. So there was no option about the thyrodectomy. But I think we already discussed, and I think I've got the same philosophy. We've done some work on the invasion of the thyroid, both in primary setting and secondary setting. We sent the salvage surgery series for publication recently, and there is a similar kind of rate of invasion both in the primary setting and the secondary setting, which is around about kind of basically 7 to 8%. The next thing that obviously, Vin, you mentioned is the necks. So would you do the neck? Would you do a bilateral neck? Would you do an ipsilateral neck? Or if you got an end node with a kind of PET scan and very thorough assessment, would you do a neck or not?
So I don't know what his radiation field was earlier. If he had a T1 disease, so a small 5x5 field for the larynx alone, then I would do his neck. So but if it's the previous,
so he had a T2, which was transglottic. So he had obviously a slightly larger field.
Wider field.
Yeah. Jay, you want to comment on that?
If the imaging doesn't show any neck nodes, particularly if there's a PET CT, no nodes, I wouldn't do neck dissection.
Yeah.
Regarding the valve, I do prefer primary valve puncture even for salvage laryngectomy.
Okay.
Especially as Vin said, there's radiation is not involving the lower area. If I find during the operation my tissues are really good, and I do put primary, and I don't have any complications.
That's interesting.
And also thyroid, I don't do thyroidectomy on that side unless if there is any macroscopic involvement or a reach for a T2 or T3 cases. For the free flap, I would consider, but if the pharynx is reasonably wide, if the tumor is involving only the anterior area, I have done primary constructions, even without the flap, they are fine. But you could consider a good radial forearm flaps or a thigh flap for this case.
Yeah. Johan, what would you do with the neck?
Yeah, well, first from a thyroid point of view, I think it's important to take out the thyroid on that side because the patient has got subglottic tumor extension, so you want to clear the paratracheal nodes. The neck, my concern here is he's not a very reliable patient, and so I'm not sure he's going to present early with any nodal recurrence. So I'd probably be a bit more proactive towards the neck from that perspective, and that also counts in our practice where you have to decide whether the patient are going to be reliable in terms of follow-up. And in terms of a flap, we wouldn't bring in a flap. This has been a small radiation field, and we just treat it like a primary total laryngectomy case.
Yeah. Unfortunately, in this case, what actually happens from the March last year to March this year or to February this year is that the tumor had progressed. So we went from a T3 to a T4, and then there was basically parapharyngeal kind of space involvement on the left-hand side, which is basically made it a T4. So we did do a flap. So the voice prosthesis issue, we've been very conservative about voice prosthesis because we had a kind of our early kind of experience on salvage laryngectomies was actually really pretty poor, and we had a lot of kind of breakdowns, especially when we did put flaps, possibly because those patients had chemoradiation rather than radiotherapy alone. And I think there's something that we do have become extremely conservative about. So I just wanted to ask Farouk, what's your approach in Sydney about voice prosthesis in salvage laryngectomies?
I think it's, as I said in my talk, I think it's surgeon dependent. I do primary placement. I think unless the radiation field has gone into and beyond the cricopharyngeus, I just think one procedure is adequate, but some of the surgeons do it as a secondary voice. I used the Provox at the time. Some of them do it as a secondary. I think free flaps we would routinely do because I don't think it's just about the leak rates. There's pretty good evidence that functional swallowing, particularly in salvage scenario, is better with the flap. The pharyngeal diameter is better. The voicing is better. So there are functional benefits to it beyond just a reduction of leak rates.
Yeah.
And ipsilateral thyrodectomy and no neck dissection except to find the vessels.
Yeah, that's good. Vin, you wanted to had a comment on this.
So sorry, I'm going to jump into another meeting now. So okay. I'm really happy.
No, that's fine. I'm just going to.
There are 3 questions to be answered by the panelists. Okay, lying on the chat.
Let me just finish this. So this is basically what we did with this guy. So he had basically total laryngectomy. We did a little bit of a kind of a neck dissection where the tumor came from, and he had basically a double island flap, which we normally do for these cases. And so we, because he had a laryngectomy, had a tracheostomy before, we quite like to have the kind of the area augmented. So he had a patch, preserve the posterior pharyngeal wall, have a patch, and he actually he's done very well actually. But anyway, it took 9 months to convince him to get him there. So the questions were, Vin, you still there? No. So I think I'm going to probably kind of call it a day. I think it's been a great afternoon, a great panel. I would like to thank everybody to give up their Sunday afternoon to for this. It's been I think it's really a great privilege. Well, I hope we're really looking forward to to see you again, face to face, to give you, shake the hand, give you a hug, and hopefully we'll, have some beers and sort of share more experience. Thank you very much, guys.
Thank you.
Thank you. Thank you very much, Ricard and the panel. And like Ricard has just said, we'll hope to shake hands and have hugs very soon. We live in hope. So thank you very much and hope to be all safe and well. Goodbye.
Thank you. Thank you.